Welcome students to Chapter 4, which is on clinical assessment, diagnosis, and treatment. And so today we are finishing with looking at how do we evaluate people when they come in with a mental health problem and what results from that. So we start our assessment of a person with collecting relevant information to reach a conclusion, or idiographic information, meaning that it's specific to the person. And our clinical assessment information is used to determine whether, how, and why a person is behaving abnormally and how they may be helped, again, specific to the person. Hundreds of clinical assessment tools have been developed and fall into three categories: interviews, tests, and observations. And the characteristics that we want to look for as we select those are that they need to be useful and standardized and have clear reliability and validity. The standardization process is very important. It involves setting up common steps to be followed whenever the measure is administered to someone. So you have to follow the rules and administer it and score it and interpret it in the way that the test developer set out. Reliability is the consistency of an assessment measure, and a good tool will always yield the same results in the same situation. So there are two main types: test-retest reliability, which is where a test yields the same results every time it's given to the same people. And then inter-rater or inter-judge reliability, that's where different judges independently agree on how to score and interpret a particular tool. Validity is when we're looking at the tool's results. Does it measure what it says it's supposed to measure? And there's three specific types of validity. Face validity has to do with appearance. It's really more on the surface. Does it appear that it measures what it's supposed to measure, but it doesn't necessarily indicate true validity? Predictive validity is where we're looking at whether a tool accurately predicts future characteristics or behavior, such as when we give an IQ test, we know that those predict academic achievement. And then concurrent validity is where a tool's results agree with independent measures that assess similar characteristics or behavior. So we would, for example, take a look at how different IQ tests, measure the same or similar characteristics or behavior, and if they stack up together. Another part of our process, once we have determined what we're going to do, is to conduct clinical interviews. We have a face-to-face encounter with a person. We collect basic background data. We can give an unstructured interview or a structured interview that may have been developed by a test developer of some kind. An example is a mental status exam, where we're looking at whether a person is oriented to time and place to see if they have dementia, for example. Clinical tests are another part of the assessment. These are used to gather information about psychological functioning, and we can infer broader information from them. Projective tests require client interpretation of vague or ambiguous stimuli or open-ended instruction. They are psychodynamic in orientation, and they are things such as the Rorschach test, the thematic apperception test, sentence completion test, and projective drawings. And you can see a Rorschach ink blot here. So people are asked, what might this be? And then their results are compared with results of people from all walks of life to see if what they're reporting is consistent, and if not, it may be indicative of some psychological malfunctioning. This picture is similar to one used in the thematic apperception test, and in this test, people are asked to tell a story that has a beginning, middle, and end, and their responses are analyzed because we tell our own stories, and so there's some psychological information that we can glean when we know what people are going to respond to different scenarios like this. We can give sentence projection tests or completion tests as well that start with stringers like I wish or my father, and they fill in the blank, and that also tells us kind of some of the content of their thoughts. Drawing tests are commonly used to assess the psychological functioning of children in particular. In this case, you see a Nigerian refugee child who is drawing an attack scene that he experienced. But children are frequently asked to draw pictures of their families or a house, a tree, and a person, and some of those results are analyzed together and with other information to try to draw some conclusions about a child's psychological functioning. Personality inventories are designed to measure broad personality characteristics. They focus on behaviors, beliefs, and feelings. They're usually based on self-report. The most widely used of these is called the Minnesota Multiphasic Personality Inventory. For adults, there's a version, and for adolescents, there's a version as well. And then there are individual response inventories that are based on self-report. They focus on one specific area of functioning. So if a person presented saying that they feel anxious and depressed, we might give them a depression and anxiety inventory. They could also receive social skills inventories or cognitive inventories. There's lots of different kinds. Psychophysiological tests measure physiological response as an indication of psychological problems, things such as heart rate, blood pressure, body temperature. We used to see a lot of use of polygraph or lie detector tests, but we don't see that as much anymore, but that's another example. The more common tests that we see that are given to look at brain functioning are things such as an MRI, and you can see a normal MRI there on the left. There's a CAT scan in the middle that reveals a mass of blood within a brain. And then on the right-hand side, there's a PET scan that shows which areas of the brain are active with red, orange, and yellow when the brain is being stimulated. Intelligence tests are designed to indirectly measure intellectual ability. They typically consist of a series of tests assessing both verbal and nonverbal skills. There's a general score that is an intelligence quotient or IQ, and that represents the ratio of a person's mental age to his or her chronological age. We can also do clinical observations as part of assessments, and they're very frequent, especially in schools. Naturalistic observations occur in everyday environments. Sometimes psychologists do those, and sometimes they're made by participant observers and reported to a clinician. For example, a parent or a teacher might report something to a school psychologist that they observed. Reliability and validity are concerns with these observations because everyone focuses things through their own lenses that can be biased. So we have to watch out for that. If naturalistic observation is impractical, sometimes we do analog observations, and these are used and conducted in artificial settings. So once we've gathered our information, then we use a classification system to classify a disorder. Using all available information, we paint a cluster of symptoms or syndrome and make a diagnosis. There's a determination that a person's psychological problems constitute a particular disorder, and it's based on, in our country, mostly the DSM-5, which is now in text revision. This is short for the Diagnostic and Statistical Manual that's published by the American Psychiatric Association. And so we find in there categorical information that's indicated by the client's symptoms. And then we also find guidance on how to rate the behavior dimensionally. So in terms of how severe the client's symptoms are and how dysfunctional they are across different dimensions of personality. DSM-5 categorical information, for example, may include anxiety disorders or depressive disorders, and you can see lots of subcategories underneath those. So we would choose the one that is correct, or more than one, and then we would assess dimensionality or severity. And we want to make sure that the client's syndrome is matching a known disorder because misdiagnosis and reliance on clinical judgment without a lot of good analysis can lead to poor treatment. And so we definitely want to make sure that we've got the correct disorder. And even if we do have the correct disorder, we know that labeling may create a stigma for a person and lead to a self-fulfilling prophecy. And we want to avoid that and try to head that off when we approach treatment. We don't want to have people attach themselves to their diagnosis and then persist in the symptoms. We want them to overcome those. And then finally, treatment decisions begin with assessment information and diagnostic decisions to determine a treatment plan. We do use a combination of idiographic and nomothetic information. Idiographic, remember, is specific to the person, and nomothetic information has to do with information that cuts across a group of people or society. So that helps us to know, where the person falls in terms of everybody else. Then we look at other factors, including if we know their therapist's theoretical orientation, we may want to tailor treatment based on that approach. We want to make sure that we've included current research as a guide to practice, and look at the general state of clinical knowledge. Currently, there's a focus on empirically supported and evidence-based treatments, and we want to make sure that we include, treatments that have some support in the literature and can produce results for a person. Finally, this graph, I think, is really helpful in understanding that there's different pieces to success in treatment. Specific therapy techniques only account for 15% of a person's success rate. The expectancy of therapy success is equally valid at 15%. And then look at 30% events in the client's life, such as social support, fortuitous events, spontaneous improvement. All of that matters more than anything. The client-therapist relationship is 20%, so we need to make sure that we've got a good relationship going with our clients when we treat them. And then the therapist and client factors, things that are specific to you as a therapist and your client as the client, are also important at 10% of the pie. So, and client factors, therapist factors, and the therapist-client relationship are called common factors, and you will hear that as you go through your training more frequently. So all of these things come into play when we think about how the client might be helped. And we will be looking at more specific treatment information in other chapters. And I will take up with Chapter 5 next.